Hello, everyone. Good evening and welcome to ICPA Clinical Series. And today is our 18th episode. And today we have a unique topic, which we have received great response on social media. It got a lot of people wonder about this unique, what you can say, accomplishment achieved by one of the practicing dentists in India. And it is unique because today's speaker, Dr. Priyanka Sakhavalkar, is an exclusive oral medicine practitioner. She practices in Nashik and her practices exclusive oral medicine. And the moment we posted it on social media, people were wondering how is a private practice be built, can be built around oral medicine alone. What is the scope? What is the potential? And a lot of oral medicine MDS people also asked us since how long she has been doing it, what is the response of fellow practitioners in that city, and how has been the sustainability of this kind of practice. And looking at her work, all that I can say is it is her passion and the kind of purpose she has found in oral medicine that made Dr. Priyanka Sakhavalkar start her practice, build her practice around oral medicine, and enjoy it and take it to the next level. And it is not just her private practice in oral medicine. There are a lot of things she has been doing in oral medicine. She is the founder of Diagnosure Oral Medicine and Radiology Clinic in Nasik. That's the name of her clinic. And it is one of India's very few dedicated, exclusive, and advanced oral medicine and radiology clinics. Dr. Priyanka is the winner of Magna cum laude award for the best research poster at the European Congress of Radiology 2022. She is also an invited international speaker with international publications and conference papers. And her UK experience of working with advanced imaging modalities at the prestigious University College London, and she has worked on radiomics, which I'll be asking her about what is radiomics. It's a new term for me. There are so many omics nowadays, and radiomics is certainly one very new in that. And she calls radiomics the future of cancer imaging. So a lot of her research revolves around cancer, pre-cancer lesions, and the side effects of cancer therapy, oral mucositis, and related things. So we'll be listening to her today, and I'll also be asking her about her journey in oral medicine because a lot of viewers want to see her journey and get inspired by the things she has been doing in oral medicine. So, welcome, Dr. Priyanka Sakhavalkar. Welcome to the show. And I have my questions for you. Before you start your presentation, I want to ask you some things pertaining to your own journey. What was your perception about oral medicine when you were doing your BDS?
Okay, first of all, hello and good evening, everyone. Thank you, Dr. Rajiv Chitguppy, for this opportunity to speak with all of you. And I'm very delighted to be here today. When I was in BDS, I did not know a lot about oral medicine. And just like any other, I thought it's one of the non clinical subjects which we study. Radiology was a bit interesting, but I never felt very much inclined to it. And I came to it during my post graduation. I came to it by chance. But till when I actually started doing it, I did not know its potential and what all it really contains.
Okay. And when you took OMDR as your MDS specialty of your subject, what was the thought behind it? Because you are getting OMDR, or was that the time where you had seen some potential or connected with some purpose?
I think it was by chance. I did not know the potential that time.
Okay, okay,
But
okay,
now, today, I'm very happy that I took OMDR and I feel blessed that I took OMDR.
okay. And how was your PG in OMDR? Was it eventful or anything that inspired you to take OMDR seriously because we see many people, not everybody, there are many people who do OMDR. They open a private practice and they do all good dentistry, they advanced dentistry, they do clinical practice, they do. But when was it that you realized you should be doing an exclusive oral medicine practice?
I think I realized it quite early during my PG days that I will be doing exclusive oral medicine practice. I feel that I'm a little late on starting this journey with Diagnosure. It's a very new project, and I started with it in October. It's not even a year now when I've started with it. So I started realizing its potential, and I found it very interesting that it's not any subject. You need a lot of brain. You have to look at the patient. You have to think about his medical conditions. You have to look at so many things before coming to a diagnosis. So I found it very challenging, and we have to study medicine. We have to study so many things. And with the radiology, CBCT was coming up when I was a PG, and that time our college did get a CBCT machine. But again, I was interested with orofacial pain and TMJ. So my MDS topic was comparison of ultrasonography versus MRI for
Okay.
TMJ, and I found radiology interesting since that time. And I thought that there is a lot of potential that we can do as oral medicine physicians. And also, I could see a lot of patients who are not treated well. They don't know what it is. There is no awareness. People don't understand what is oral medicine, and unfortunately, many times even our dental colleagues don't understand the potential it has while
Okay.
treating the patients.
Okay. So now you said the TMJ imaging. So if I ask you what component of your practice is TMJ related and what part of your practice is cancer related?
My entire practice is only related to cancer, pre-cancer, TMJ, orofacial pain, everything.
Okay.
So
So
right now I'm
TMJ.
only focusing on the pre-cancer and cancer part and CBCT. So I've started with CBCT also,
Okay.
and I will upgrade with more with TMJ in the coming future.
Great. Great. And after MDS, you thought of doing your MSc from London.
Yes.
What was that about? Or like how the topic was unique or special compared to your MDS or MDR?
What happened after completing my PG? I moved to Pune. There, I was practicing at a CBCT center, and I was also doing private consultations only with oral medicine and radiology. And that time, I was getting very good response only with the oral medicine. But while during CBCT reporting, I thought it's very monotonous and I need to upgrade, I need to learn more. And with my passion for research, I applied at advanced biomedical imaging at University College London. So
Okay.
University CABI, which is the European CABI, which is the Center for Advanced Biomedical Imaging, where I studied this MSc, is the largest preclinical imaging center in Europe. And here I learned all the advanced imaging modalities like functional MRI. My research was on functional MRI there, then PET, SPECT, all everything. And I also learned neuroimaging, even animal work. All these things I learned at UCL.
Okay. So this radiomics was a part of your MSc only?
No, radiomics was not part of my MSc. When I started PhD, I was looking for some. I knew that the topic of my research is pediatric brain cancer imaging, and we wanted to study the post radiation changes in pediatric brains, because pediatric brains are more sensitive to changes due to radiotherapy, and we were trying to find some quantitative MRI biomarker. That time I looked into literature and I was searching for what could be the something which will be very, which has the potential and which is very good, which can be very good. That time I was going through different articles, different organizations, different conferences, including RSNA, so Radiological Society of North America, where I did my presentation in Chicago last October. So during that I found that radiomics, and I got very fascinated with the concept of it. And our research group is the first one in the world to do this research in to study the pediatric brain, the non-tumoral regions with radiomics.
Okay, great, great. So before I ask you more about your award, I want to read out a comment that has come right now. Dr. Ruchika Prasad. She has written oral medicine is the basis of any good clinical practice. So, a lot of good and successful practitioners have OMDR as their base. I am glad we are breaking the myth surrounding OMRD being a non clinical branch, and I totally concur with what she has written. Okay, coming back to your journey, I want to know about the award, the Magna Cum Laude award that you have won this year.
Mhm.
So, can you tell us more about it?
Magna Cum Laude is the award which is given at the European Congress of Radiology. And European Congress of Radiology, different papers and posters, research posters are invited from all over the world. So around 8,000 entries are there from all over the world. And among those entries, they selected few of the research papers or posters. Though it is called as poster, it is not really a poster. It will be published as a paper soon. So it
Okay.
is a very short version of a paper, and in that they select the some of them for the presentation. So for the my initially my paper was selected for the presentation in March, and after they select it, they scrutinize it, and among those they select few for the Magna Cum Laude and two other prizes. So Magna Cum Laude is the best one,
Okay.
and for my poster got selected for that, where I had tried to study again pediatric brain cancers, where we tried to compare the qualitative and quantitative changes in these brain cancers, and tried to see that what is the validity of radiomics and could it be used for the clinically. That was the main aim in that paper.
Great, great. Very, very inspiring. And
Thank
today, your topic is also very relevant. That let me just tell our audience that you'll be speaking on rising need for oral medicine specialists in enhancing the life quality of cancer patients. We'll continue our discussion. Before that, I wanted to start with your presentation.
you. Okay. So, good evening, everyone. First of all, I would like to thank you all for joining in today. I will start with the quote by famous French physician, the Alexis Carin, which is the quality of life is more important than the life itself. Now, I would ask a few questions. First, have you ever had an ulcer in your mouth that was painful and stopped you from eating? Have you ever experienced a burn on your palate from hot cheese and you had a different feeling for 2 3 days? Now, I'm sure all of you must have experienced at least once in your life, and some of you have several times. Now, imagine not being able to enjoy spicy food, but even a routine meal for 2 months, 6 months, 2 years, or just have to eat milk and chapati or any bland food. The continuous discomfort of oral ulcer in mouth for not just days but months and years. Can you believe people turn helpless and they cry for not being able to enjoy simple food with family and friends? Can you help them? So, with this background, I would like to present my topic, the rising need for oral medicine specialists in enhancing the life quality of cancer patients and even others. I will not only be talking about cancer patients, but I will also be covering, depending upon the questions which I received for this lecture, I will be covering pre-cancer areas as well. So, starting with my journey, like we already started, I passed my BDS, then I practiced for a while, then I went for MDS in oral medicine radiology. Then I went ahead, did some specialty practice in Pune for a while with my passion for research. Then I went to advanced biomedical imaging at University College London. From there, I was selected for PhD at University of Liverpool for the Alderhay Children's Hospital, and I completed my PhD and I came back. I've recently passed my Viva as well, and I started with my oral medicine and radiology clinic, which is DiagnoSure, which is a dedicated clinic. Now let's start with the two. I have divided my presentation in two parts. The first part, as I call it, as don't worry, it's not a cancer. Many times, patients have lesions in their mouth and they are painful. They consult physicians, cancer
Dr.
specialists.
Priyanka, just check if your slides are moving.
Yes.
Not still, we are on the first slide. Now it is moving. Now they are moving.
Can you see?
Yeah, now we can see your fourth slide.
Okay.
Now,
Now.
please make it full screen.
Okay. Can you see now?
Yeah, now we can see the title slide.
Okay. Now I'm changing the slides.
No, 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 they are not moving. Now they are moving. I think they are moving slowly.
Okay, so again I'll go back and see if they are moving. I'm sorry for that.
No problem.
Are they moving now?
No, no, there's it's still the fourth slide. It is not yet full screen. It's not in the slideshow mode.
Use slideshow. Can you see now?
Can you go to the first slide?
Yes. I think I got what it is happening probably. Which slide can you see now?
First slide.
Now?
Now third slide. Now it is moving.
Now?
Yeah, yeah. Fourth slide. Title slide. Yeah, now it is moving.
Okay. So I think I will use this view. It is better.
Yeah.
Can you see full screen now? So is it okay now? Shall I continue?
Now we see the no, not the full screen. We see the slide and the content.
Okay, now I got it. What you can see. I think there is some problem with it.
Just go to slideshow mode.
Can you see the slideshow now?
The slide is actually very small. The size is reduced. I think you have resized the window.
What I'll do is, now is it better?
Yeah, now it is good. Now it is good.
Okay, so I'll keep
Yeah,
it like
now
this.
yes, yes, yes. Now it is perfect. Yeah, good to go.
Okay, so I'll start with the first part of my presentation. It's don't worry, it's not a cancer. So many times, patient feel ulcer and they visit from physicians to physicians, but they do not get any relief, and all they are told is, "Don't worry, it's not a cancer." Now I'll start with my first slide. This is the first case. Sorry, I'm not getting the animation which was there. So this is the case of 50-year-old female with the severe burning sensation in her mouth, and she was unable to eat since past 3 months. For the past 3 years, she has consulted different physicians, ENTs, dentists, but she did not get any relief, and they were considering taking a biopsy because it was not healing since a very long time. And then she happened to come to me for the this lesion, and we started treating her with the typical treatment for the oral lichen planus. And after a month, almost a month, there was no burning sensation in her mouth, and patient was eating normally. She did not have to take any biopsy, and lesions healed very properly. So there are more images where the lesions are completely healed. Coming to the second case, this is the second case where there was a burning sensation in her mouth. She was feeling this burning sensation. Been to ENTs, had done biopsy twice, but she did not get it was found non-malignant. So again, since it was not malignant, it was not treated properly. Every time she went to the doctor, she was told that okay, it will be fine. She were given some drug, but they were not helpful. Again, she came to diagnose her. We treated her with typical treatment, and we treated her with low level laser therapy and treatment for lichen planus. And within a week, there was no burning sensation. We got a very good healing, and this was bilateral. In fact, this lady even underwent extraction of the tooth, because somebody thought that it is because of the irritation because of the tooth. But even after reduction or extraction of tooth, there was no relief for this lady. But with the low level laser therapy and the treatment, topical treatment, we got a very good results. In 1 week she was very happy. Now this is the another case where I would like to mention that many times patients take steroids from local physician, or they take it from the over the counter from pharmacist. These might be good for pain relief, but they may not be sufficient. For example, now in this case, this was the 76-year-old lady with some urological medicines, and she had underwent multiple extraction. Patient was on triamcinolone, which was a steroid, and she showed no response. In fact, it aggravated the lesion. If you see, this was the lesion. Again, she came to us. We stopped triamcinolone. We gave her treatment for candidiasis, and within 4 5 days, there was reduced burning. Her all these whitish lesions were healed, and patient was very happy. So what I wanted to talk in this is that many times what happens, unfortunately, if it's not a cancer, patient undergoes biopsy, but if it is not a cancer, it is not treated. So is it sufficient to take a biopsy and leave the patient? These lesions, which are precancerous or which may not be precancerous, but they are painful, and they affect the quality of life in these patients. So they need treatment, they need correct diagnosis, and they need correct treatment. Many times these ulcers don't heal, not because they are malignant, but because they are not treated properly. This is why I feel the role of oral medicine specialist is very important, to diagnose this lesion and treat them so that they do not turn into malignancies. So let's go through some of the numbers. Prevalence of oral lichen planus in South India is around 2.6% of population. Prevalence of recurrent aphthous ulcer in North India is 21%. Prevalence of OSMF in India is about zero point 0.2 to 2.3%. So it all comes to around 25% of the population is suffering from all these oral medicine related conditions. Now, everybody knows oral cancer statistics. Over 5 people in India die every day, every hour, because of oral cancer. And approximately 70,000 new cases and more than 48,000 oral cancer related deaths occur every year. And India is oral cancer capital of the world. That's what this paper says. So why is it important to detect? Obviously, to decrease the morbidity and mortality of oral cavity of tumors, to improve the quality of life of patients with oral cancers, and of course to prevent cancers. And that is the reason why biopsies are taken. But several times these biopsies are not needed. I'm not saying that don't take biopsy. Of course, biopsy must be taken because it is always important to detect a cancer. But it will always be helpful if there is some specialist who can tell you that, okay, let's try for a week whether these lesions can be healed or not with a proper treatment. Now, why is it important to diagnose and treat non-cancer? So this is what I wanted to talk about. First is patient's well-being, enabling daily meals, nutrition, and well-being, and prevent cancer whenever possible. So many times these patients come to me because they have been to different specialists. They come with the stacks and files of from all the specialists, and everybody tells them that don't worry, it's not a cancer. Yes, but they are not able to eat. I've seen patients crying in my chair and telling me that it is not possible for them to have simple food which we eat every day. So this is the area which I feel needs a lot of attention, and we need to help these patients in making their lives easier in whatever way we can, and of course prevent cancer whenever possible. If there are lesions, they are treated properly, they may not turn into cancer. Not all the cases, but some of them, obviously, we can prevent them. And here I would like to make a point that please treat non-cancerous lesion, and if needed, consult referral to a oral medicine specialist for diagnosis. Don't leave it because it's not a cancer. Now I'm coming to the second part and the final part of my presentation, which is congratulations, you have survived. It's nothing serious and it will heal. Uh, is it enough to treat just cancer? What do you all think? Again, I'm coming to another case. This is the lady patient who came to me with the pain, painful ulcers in her mouth. She had undergone surgery for tongue cancer followed by radiation therapy, and it was 1.5 year ago. And since 1 year, she was having this ulceration and inflammation, whatever we can see. I don't know if you can see my highlighter. Okay, so this so these all these lesions were there since a year, and patient was not able to eat any solid food. She was looking pale, she was looking very weak, and she was very unhappy because there was a restricted mouth opening, there was xerostomia, and all other symptoms because of the radiation therapy. See, there are very well known oral complications of the treatment of cancer. Because of surgery, there is a test loss, mucositis, thrush, dry mouth. Radiation therapy causes dry mouth, radiation care is trismus. And 40% of the patients receiving chemotherapy for any malignancy will experience oral complications. But what happens? Many times these patients are not aware of these side effects of the therapies, and they keep suffering. They are not properly treated or given proper attention when these post cancer side effects show up in their mouth. Most of the times it is like they are healed with cancer, but quality of life is equally important. Agree, they are alive, but they want to eat, they want to have simple pleasures in life like we all have. Now, oral mucositis is a very well known complication of radiation therapy. And the mucositis study group of multinational association for supportive care in cancer and international society of oral oncology, which is MASCC group. This group establishes the guidelines for the management of oral mucositis. I want to take this opportunity to create awareness of this oral condition which many patients under suffer from, and it needs treatment. I had done my own research about the awareness of oral mucositis and the different mouthwashes that are used for this. And it was done back in 2011 along with the Tata Memorial Hospital. And we were found that there was urgent need for setting up the guidelines. According to MSCC, there are different ways to treat this oral mucositis. First is pain control, nutritional support, palliation for dry mouth, oral decontamination, and therapeutic intervention. However, along with that, there is one therapy known as low level laser therapy, which is supported by this MASCC. And they're giving this therapy along with the radiation cycles can prevent oral mucositis. And it is very important that people understand the importance and usefulness of low level laser therapy in prevention and management of this oral mucositis. Now, this lady was treated with low level laser therapy, benzidamine, and other oral topical mouthwashes and topical paste. And this is what we got within 1 week. We could see that this inflammation, this is the reddish, this is gone. Look at this inflammation of the tongue and this buccal mucosa. The erythema is gone. This inflammation is also gone on the tongue. I'm showing up the rightmost image. I'm not sure whether you can see my screen and my pointer, but if you see the rightmost image, you can see that there is a difference between the tongue in last two images. So patient was very happy. She had started eating solid food within a week of therapy, and this lady was suffering from 1 year. So, this is what is the role of oral medicine in treating these patients, even before cancer and after cancer also, because quality of life is important for everybody. Now, coming to take home message, first, quality of life is important. We can prevent oral medicine, oral mucositis. And there is an urgent need of oral medicine consultations to diagnose and treat lesions that are not cancer. And treating these lesions, the precancerous, which are not yet cancer, may prevent cancer. And overall, it will improve the quality of life. Thank you for your attention. And you can reach me on email address. You can visit my website, and you can contact me on any social media if you have any queries. Thank you so
Thank
much.
you. Thank you, Dr. Priyanka. It was so well summarized, and you have covered so many vital points. Some of the points that I could gather in this presentation, the first and the foremost was the quality of life is more important than the life itself. That is the first thing. Second, people want to see whether it's a cancerous lesion. If it's not cancerous, they leave it because there is no fear or no worry with that associated with that. But you made a very clear point that you need to treat even if it is not cancer. And you showed the number 40% of people who are undergoing cancer therapy suffer with one or the other type of oral complications. And what I liked about was in the oral complications, especially oral mucositis, you made two clear parts. One is prevention, where you said you need to make use of low level laser therapy, and as other side you showed lesions that you cured where there were already lesions where you used benzidamine. So I want to ask, what has been your experience with benzidamine? Benzidamine has been recommended by this MASCC since many years. How has been your experience with that?
It is good. Benzidamine is good in oral mucositis. We need to do some monitoring in some of the patients when we are doing using benzidamine.
Okay,
Another thing which I found is that xerostomia. So xerostomia also needs to be corrected in these patients.
okay.
And there are
So
artificial salivary
benzidamine,
substitutes.
yeah, benzidamine when you prescribe, what is the usual duration after which they start showing good, relief?
Benzidamine can show relief in 4 or 5 days, but I've never used it alone. I use it with other supplements, and we need to monitor when we are using benzidamine whether patients are showing the relief or they are having some burning sensation or not. It really depends upon what stage of mucositis it is, and generally patients show very good relief within a week also.
Great, great. And another complication of oral complication of cancer therapy has been dry mouth. So
Yes.
how we have been managing dry mouth cases? Because although it appears like people may not realize that they have dry mouth, but somewhere or the other it will be coming in the way of their daily activities like eating, drinking, and speaking.
Yes. So when we are treating patients with mucositis, we are doing multiple things together. So we use benzidamine, we use artificial salivary substitute. So right now, presently, which I found very good is the wet mouth, which I routinely use for patients, and it is giving good results in patients with oral mucositis. Patient tolerate it very well, and they feel that xerostomia reduced a lot. And then we do add different mouthwashes, and even in one of the research, if the salt water gargle, salt soda, and lukewarm water, those gargles are also helpful. So we ask patient to do all this along with the low level laser therapy.
Great.
It works very well. So it's a complete therapy which needs to be given with the patient. There is no one point solution. And most importantly, for all these patients and all these lesions, they need monitoring. So if we are prescribing steroids, it's not like you prescribe them and you forget about it. We make a point that we call them up every week. We see whether they need monitoring, whether they need to reduce the dose, increase the dose, whether they are healing, what is going on, or we need to stop all this and go for biopsy. So monitoring is very important part in all this, and that's why we need somebody dedicated to look into these patients.
Great, great. We have a, I'll just ask a live question that has come right now. It is by Dr. B. Srinivasan, who has been a speaker for one of our earlier episodes and who has been doing fantastic work in maxillofacial rehabilitation for cancer patients. So he says management of radiation induced mucositis is an unmet need. Why do you think radiation oncologists are not reaching out to people like you? And what has been your experience with radiation oncologists?
I don't know why they are not reaching out to me, and I am trying to reach out to them, but I'm not getting the response which I'm looking for. I don't know why. In fact, I today I take this opportunity to create awareness so that every all the specialists are involved who can really help patients.
Great.
But I would
And
like
Dr. Srinivasan himself should take some initiative in this because he has his own his own network of hospitals and specialists who are working with him in rehabilitation and
Yeah, but
somewhere
here
it
I would
should.
like to here I would like to take this opportunity to mention that I got to know about oral mucositis because of the radiation oncologist in the Tata Memorial Hospital, Dr. JP Agarwal. So he was
Okay.
the first one who encouraged me to carry out a research on mouthwashes and their awareness, and that is how I started getting to know for this. So I look
Okay.
forward to work with you too, sir.
Okay. So let me ask you a few questions sent to us by our the people who have registered for this show. Um, what are the most commonly used nicotine replacement medicines or drugs which are effective and helpful to the patients, and what has been your experience?
First and foremost, first patient needs to be willing to do it. Some of the patients they agree, and some of they get scared with the when we explain it to them that it might turn into cancer, that you have to stop it now. So that time some of the patients by that only they leave it, and some of them we need a lot of things. Firstly, we do need a nicotine replacement like chewing gums, and there are patches. But there are some groups who are working on no tobacco, which do the counseling, and there are support groups which needs to be more developed. I don't know, looking for these things in Nasik where I can establish this, or I'm planning to start one, the tobacco cessation group in my clinic itself. But there are groups in Mumbai, and there are people who are working on this to stop the tobacco.
Okay, okay, great. Can OMDR specialist perform radiotherapy and chemotherapy by playing role as oral oncologists?
I don't know, I don't think so. For radiotherapy, radiotherapy and chemotherapy, they are very specialized branches of medicine, and they need very extensive training. I don't think radiation, it will be way out of the syllabus for radiation oral diagnosis specialists to do all these things, because whenever the good practice of oncology, I have seen this in UK as well. So in good practice of oncology, it's always a MDT, that is multidisciplinary team, where radiation oncologist, even medical people don't work together like that. Mediation oncologist, medical oncologist, surgeons, radiologist, everybody sits together, they work as a team, they decide who is going to do what part, and they do the decide the best treatment for the patient.
Okay,
So I wouldn't go that far.
okay. What is your experience with the use of saliva substitute, artificial saliva substitutes available in relation to oral mucositis and cancer therapy patients?
Yeah, my experience is good with the wet mouth, and we do give other instructions to patients that eat frequently, give chew the vitamin C tablets and other things, the soft diet, liquid diet, all other things we supplement with that.
Okay. Now, apart from questions, people have. Let me increase my view. I'm just reading out the questions. Um, there are some people who have sent their opinions rather than questions. To increase the scope of oral medicine, all MRI, ultrasonography, USG of head and neck region should be performed by OMDR people, including reporting. Plus, all radiotherapy of head and neck cancer should be performed by oral medicine, oral and maxillofacial radiologist. Then somebody has suggested gene therapy center should be increased and practically should be made available even in rural areas. And somebody who is looking for higher education in this field is asking, does India offer a course pertaining to oral oncology that can be made eligible for OMDR specialists? Want to answer this?
I'm not aware of. There are some courses in oral oncology, but they are not in India. I don't know if there are any courses in India. And
Okay.
what I have realized that oral oncology in India sadly still focuses only on prosthetic part or on the surgical part. Still, oral medicine people, I don't know whether they are allowed to enter the field of oral oncology, because most of the fellowship, when I was just newly passed MDS specialist, I realized that I was not eligible for any oral oncology courses, because they were admitting either the fellowships are available for prosthodontics for the prosthetic rehabilitation, and fellowships are available for oral surgeons for the surgical oncology. But
Okay.
nobody has addressed this need where oral medicine people can have a unique role of diagnosing and treating pre-malignancy and even post-cancer changes.
Okay. Uh, there is one funny question. It says, "What is your reaction when somebody forwards you only a clinical pic and asks for a diagnosis?" Which is a common scenario faced by OMDR specialists.
Yes, it's very common. It's a free consultation.
I have done that. I've been asking my friends because you just get stuck. You do your best, but you don't come to the diagnosis. So what you do is you just take a photo on your mobile and send to your OMDR specialist, and they have
I
been
would
very kind.
I would encourage them to refer them or invite oral
Yes,
medicine specialist for the consultation.
great, great, great. Okay, laser therapy for precancerous. I think you have detailed it. Low level laser therapy, and how can I differentiate oral cancer and other lesions in the oral cavity at an early stage when the patient comes for routine checkup?
It is there can be whole another lecture on diagnosing
Yeah,
the
yeah, yeah,
cancer,
yeah.
but a few points I would highlight it. Look at the patient if he has any habit, if there is any long standing ulcer which is greater more than 3 weeks, if there are any lumps, if there are any lymph nodes, if there is some unusual picture like sudden mobility of tooth, only single tooth is mobile, if you can see anything radiologically, and best whenever is doubt, get a referral rather than extracting a tooth which is in the region of malignancy. Don't only look at the tooth or the crown or the implant. Look at the entire oral cavity. Look at the buccal mucosa. Look at the tongue. Look at the palate if there is anything.
Okay, okay. In our routine clinical practice, when we plan multiple root canals or any other clinical treatments, how to control the emotional issues in such patients as they are tired of so many long treatments. Also, these patients have dry mouth and severe gagging.
Mhm.
Rubber dam has helped me personally a lot with such cases. I need your opinion in such cases.
I think I would look into the medical history of these patients, that why they have dry mouth, why they are not emotionally stable. Keep the appointment short. That's what I would say. Speak to the patient, ask them what makes them. Many times I refer patient to the psychiatrist or the counselor when I see that there are a lot of some emotional issues which are making these patients' conditions worse. And this is very common in patients with orofacial pain or TMJs. So do not hesitate to consult with the physician or the psychiatrist whenever it is needed. Because if it is dry mouth, if it is cannot be treated locally, then we have to start with a systemic therapy, which oral medicine people do. But besides that, also I do write a frequent reference to the physicians and ask them look into the medicines which they are given, ask them whether their medicines are causing this dry mouth, and request them to replace it with something excuse me, which will be better for them.
Okay. What is the price of sticking to this specialty in private practice when all people want is root canal and implants, knowing that you are a dentist? Most people are completely unaware of the services OMDR specialists provide. Also, are there any openings that offer practice in oral medicine after MDS, as it is not a lucrative branch so far? What so they want to know what has been your initial struggle as a
Initial
practitioner?
struggle is that when I started with a diagnosure, initially when I spoke to people, half of them have thought I've gone mad. That what half people ask me, oral medicine में क्या होता है? What are you going to do? So these
Yes.
were the questions with which I started. कि क्या करते हैं oral medicine में? क्या करोगी बैठ के? So this
Yeah, I
these
remember one of the questions asked on Facebook. What do? You do checkup and refer patients to others? So even I was tempted to answer. Actually, answers that she doesn't refer patients to others. It is the others who refer their patients to her whenever they find difficult to diagnose oral
yes,
lesions and they need her
yes,
specialist diagnosis. Yes.
yes.
Okay. Any views on opening career field in palliative medicine specialty for oral medicine specialist? Are there any openings? Maybe it's a career query.
I think there is one palliation medicine fellowship in Bangalore, and probably they do admit oral medicine people, the MDS.
Okay, okay. Somebody is asking about recent advances in oral cancer detection. Let me put it in this way. Now that artificial intelligence is coming up big way, what has been your experience in the early detection of oral cancer or precancerous lesions? Have you come across any AI device?
Instead of talking about AI, here I would again speak about radiomics, which is my research area.
Yeah.
So now, in brain cancer imaging specifically, and I think it is coming to head and neck cancer as well. Histopathology is no more a gold standard, because different tumors which are seen same histopathologically may not give similar response to the treatment. And to answer this question, the genomics and other things are coming up. So that is how there is the role of radiomics, where we extract the similar features from different radiological images and we try to correlate with different clinical features. And that is the initial stage where we are. And with these advanced marker, probably we might be able to improve the quality of life in these patients and also improve the life expectancy. But this is in a very early stage.
Okay.
But
Okay.
again, it is a part of machine learning, and it is very promising with whatever results it has found till now.
So there is a question. What is your experience with the use of triamcinolone as an oral medicine specialist?
I think triamcinolone is very good, but I would also say that use caution whenever steroids are given. Like one case which I presented where triamcinolone was given to that lady, and it ended up in lot of candidiasis in her mouth, when it was actually should not have given to that patient. So
Okay.
be very cautious when you use triamcinolone. Triamcinolone is a good drug, but what is important is that the dose is correct, everything is correct, the patient is right, diagnosis is the key. That is what I would say, that you are
Good.
using it for the right patient.
So it
Don't just.
works well when the diagnosis is right.
Yes.
What is your drug of choice for oral lichen planus?
It really varies.
Uh-huh.
See, the known drugs for oral lichen planus are steroids, but depending upon what is the extent, whether it is erosive, how much part is there, whether there is a desquamative gingivitis or not, along with that. Depending upon that, I decide which different drugs should I give. Whether I give triamcinolone is enough, whether I can go with beclomethasone with that, whether I should go for prednisolone. So these are different drugs, and I use low level laser therapy as well, which really helps with these patients.
Okay. This is another comment by Dr. B. Srinivasan. 1 teaspoonful each of salt and sodium soda bicarbonate in 1 liter of water and regular rinses attempts to neutralize the changing pH in the oral cavity post radiation. I think symptomatic
Yes,
relief.
yes. Yeah, was the results of my research, where we found that this is most effective in all the patients with head and neck radiation treatment.
Okay. And any experience with oral scan
For
for oral cancer detection? Oral scan.
is that well scope or?
I think similar to Wellscope.
Oral scan, yeah. And used for biopsy. It is good to use it for biopsy guidance, but you know what has happened again? I found that these scans and everything, they are misused because patients. Many people think that if the patient has a lesion, just use this and decide whether it's a cancer or not. It is not like that. It's not a cancer detection machine. It is just to supplement when you know what is there.
Mhm. So there is another question by Dr. Abhay Kulkarni. He is also trying to get into cancer research, oral cancer research, and pre-operatively can something be done for prevention of radiation mucositis?
Yes, it can be done. First, there are salivary gland protecting agents if they want to do it. But and also as a oral medicine specialist, I would say, and as per international guidelines, low-level laser therapy can prevent radiation mucositis. That's what research says. So it will be helpful if we start using it in India like it is used in other countries.
Okay. How oral hygiene is maintained in Christmas cases where patients find it difficult opening their mouth, and what kind of brushes do you recommend? Do small head brushes help here?
So you only tell about brushes.
So I can say that I'll tell. Okay, I'll tell from what Burkett says. Burkett says that you need to really use ultra soft toothbrush, very very soft toothbrushes, softer than the regular soft toothbrushes, and if you can wet them with warm water and make them even softer before use, that will minimize a lot of trauma that can happen. That can traumatize your gingiva that is already inflamed and friable. There are two questions, two people who have asked the same thing. What precautions should they take in tooth extraction in cancer patients or patients who are undergoing chemotherapy or radiotherapy?
So generally, before conducting chemotherapy or radiotherapy, before starting it, they are referred to dentists. So before that, get extractions done, and so that is the basically main important thing to prevent osteoradionecrosis. But after the cancer therapy, it is always better to consult with the radiation oncologist before going for extraction or any invasive procedure. Root canals and oral hygiene things are fine.
Okay. Okay. Uh, I guess this is the last question we are taking. What is your protocol in the treatment of oral submucous fibrosis? How do you change your treatment plan based on the severity? What to do and what not to do? In short, we can say.
Okay, so oral submucous fibrosis. First, I make sure it is oral submucous fibrosis because many patients come to you with a restricted mouth and they think it's oral mucositis, but I have sent them for a cancer treatment many times. So first, I make sure that it is oral submucous fibrosis by clinical examination and everything. And after that, intralesional therapy works very well in them. There are different intralesionals that can be given. Then the recently which has come up is the laser fibrotomy, which can cause instant mouth opening on the chair under LA, and it needs to be supplemented by the intralesional postoperatively and also the physiotherapy. These things work very well in these patients.
Okay. And what about your experience with topical fluoride applications? Because dry mouth leading to increased risk for caries.
Yes, I don't do it. I send it to dentist. That fluoride applications, I don't do it.
Okay, okay, okay. So I guess okay. Somebody who had asked the question of oral scan said it is different. Oral scan is not at all similar to well scope. Okay, and as Dr. Priyanka said, she is well versed with Wellscope and he has not used oral scan. So if you can, Dr. Meera Murli, if you can write something about oral scan, I'll read it out for the benefit of our viewers. So they'll come to know the difference between Wellscope and oral scan. Okay, so thank you everybody. Thank you for joining in. I must thank Dr. Priyanka Sakhavalkar for making this whole session so interesting, and it has been an inspiring journey for so many people who had this doubt or who had written off oral medicine. as a field which cannot be what you can say rewarding private practice, and you have busted the myth and you have shown that oral medicine can be a great private practice domain. And apart from MD, after MDS, you did your MSc and PhD. Okay, I want to ask about your PhD, submitted PhD. You just did it
Mhm.
a few days ago. When we were working
Yes.
on this webinar, you submitted your thesis. So, how was the
Yes.
defense? What was the PhD defense? How long did the exam go? And what was the experience?
Experience my viva, we had two external, and it was over Zoom, and it was good experience, and viva lasted for 4 hours. So it was quite extensive, and unfortunately I was slightly unwell that day with fever and cough and cold, but it went well. And
Okay.
I cleared that viva. They tell us immediately whether we are pass or not.
Okay. And what
After
was the topic? The 4 hour grilling viva that went on. What was the topic on?
it was on my thesis, that why you did this, why you did that, what was the rationale for this, what were the other options, how statistics works in this. So all this goes into defending the thesis, that what why we chose this, and why explaining what we did in the thesis.
Okay. Okay. How long we can give antioxidants?
I don't know if there is any time deadline for antioxidants. I generally give it for 1 month.
Okay. 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 So that brings us to the end of this session. Thank you, Dr. Priyanka. Thank you for enlightening all of us with your all research. And we wish you all the best in your future endeavors and more success with your research in cancer treatments and improving the quality of life of people who are undergoing cancer therapy. And wish you more accolades and do something more bigger and better than what you have already done in your PhD. And there will be a lot of people who are uh, eager to take inspiration from your story and do something different from what they are already doing. Wish you many more collaborative opportunities and all the best. And thank you to all the viewers for joining in, watching this session, for
Thank you
all the
very much.
excellent questions. Great feedback, registration numbers. The number, we were not expecting so many registrations today, but you all took us by surprise. And I am very thankful to all of you for your active participation. And that brings us to the end of 18th episode of ICPA Clinical Series. Soon we'll be coming up with 19th episode, and the details of which will be out on social media, and you'll all come to know. Okay, before I end, I just want to read out what Dr. Meera Murli has written. Oral scan works with the diffuse reflection ratio and oxygenated hemoglobin mapping. It's a handheld multispectral imaging camera for non-invasive and real-time screening of OPML and biopsy guidance. Thank you so much.
Okay.
And it has a cloud-based algorithm. Thank you so much. Thank you, Dr. Meera Murli, for adding your valuable points. Thank you so much. Thank you, everybody.
Thank you.
And we bring this session to an end. Thank you, Dr. Priyanka. Thank you so much once again.
Thank you. Thank you so much. It was pleasure to join you all. Thank you.
Thank you so much. Okay, let us end the session. Thank you, everybody. Good night.